Good evening, everyone. You are very welcome to the webinar, HSE Families Matter, Supporting Families on How to Respond to Drug Emergencies. The panel will be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC laptop screen. If you are using an iPad, you will find this feature located at the top of your screen. Only the panelists will be able to see your questions, and the panel will not mention names when answering questions. Without further ado, I will now hand you over to your host, Denis O'Driscoll. Thank you.
Good evening, everyone, and thank you for joining us this evening. I'm just going to share slides here to give you 2 seconds. So again, I'd like to thank everyone for coming on this evening for supporting families impacted by substance use and drug emergencies. Firstly, I think it's really important to acknowledge all the participants who are attending the seminar tonight. Meaning myself, Jenny and Nicki, acknowledge and realize the impact and damage that on a loved one and their families and the community from an overdose, the trauma and stigma and sudden loss of same. I appreciate that this will be a difficult seminar for some people tonight, and it's really important that if you need to stop attending, please do so. It's also important that you are aware that this seminar is a safe space for everyone here tonight, and that it is being recorded, but only the presenters. All participants and questions posted are anonymous. And the other thing is no one else can see anyone else on screen. There's also a poll, which is an anonymous poll, and all it is to know what geographical area you're attending from and how many are attending with you. I know in some locations there may be one participant, but there may be other people who are listening to the seminar. And it's really important that we know and understand how many people want to attend, because we're hoping that this is the first in the series which will empower families and loved ones in knowing how to respond to a drug emergency. Also, it's important just to acknowledge here in this space that to remember International Overdose Awareness Day, which is August 31st every year. And this theme is always a time to remember, a time to act. And I hope that people see tonight as a time to act. So our speakers tonight are myself, Denis O'Driscoll. I'm a pharmacist by profession. I'm also the independent chair of the HSE Naloxone Quality Assurance Group. I've got Nicki Killeen, who's from the HSE National Inclusion Office, a project lead in emergency drugs and harm reduction and nightlife. Jenny Smyth, HSE National Inclusion, who's the Naloxone project lead. As I said, it's really important that this seminar is very much for you, that a loved one impacted by substance use, you may be with them when they experience a drug emergency. And from data, it's very clear that people are not alone. It's also really important that you're able to identify a drug overdose and how to intervene and how to respond to same. The whole purpose of this, as I said, is to empower family members with the skills, but also to empower family members to talk about drug overdose, how a family member may have been lost owing to an overdose, how to come out of behind the shadows, the stigma, to reduce the stigma associated with it. It's really important that at the end of this, you are able to recognize, intervene, and respond to a drug overdose. And in the case of an opioid overdose, how to administer naloxone. So the webinar will include information tonight on the different types of drugs by Nicki, how drugs interact, how to recognize and respond to a stimulant overdose, and how to respond and recognize an opioid overdose, including administration of naloxone from Jenny. Thank you very much. And now I'll hand over to Nicki. Thank you.
Hi, everyone. It's great to be here with you all this evening. Thank you so much to Jenny and Denis for the invite. Also, thank you so much to Jenny and Denis for all the work they're doing on the really important Naloxone programme and work with families. And I think that'll be highlighted through tonight. I'm going to share my screen now with you all, and I will be looking at different types of drugs. So to start off, to introduce us to different types of drugs that people use, what are the risks, what are the HSE doing, and looking at stimulant overdose. So I suppose setting the context of substance use in Ireland, it is complex. And I suppose we always come back to the question, why do people use and why are some people at greater risk? So I suppose we don't have an answer in that it's extremely complex why some people use drugs and some people don't. There's no one size fits all. So generally people will use for a certain effect. So based on what type of drug they are using. And we know that some people may be at greater risk. So we look at certain risk factors. Could be a culture within an area. It could be opportunistic that there's drugs available in friends groups, or there could be cases where people are using for pain. They've experienced trauma, or they may be using for a certain reason for how they're feeling. In terms of why some people experience harms and some people don't, if we're looking at the short term and long term, there's different reasons. Generally, if we look at the individual person, so that can be a risk factor in terms of their physical health, if they've underlying conditions, how young a person starts using drugs, particularly how that'll impact their mental health and their coping mechanisms, people's gender. So we're starting to have conversations now about the impact of hormones on reactions to substances like crack or MDMA. Interestingly as well, we tend to overlook the setting. So say if a person is to use a substance in a certain group with certain people and they change that and use in different settings, that can increase the risk and overdose risk. And then the obvious thing of people using alone in the setting is something we advise against in harm reduction. And I suppose what's changing and becoming more complex are the drugs themselves. So the type of drugs, how much people are using across all of Irish society now. We don't just have an issue with one substance, but people are using multiple substances. So that's all different types of people across all different classes in society. We know this from our research and our data, that substance use knows no bounds anymore, and that most people are using in a pattern that increases the risks. So they are mixing drugs as part of a pattern. And that is something that Denis will highlight as part of my presentation this evening on how different drugs interact with each other. And this is the type of education that we try to provide people who use drugs themselves with an aim to help them to reduce the harms. So when we're looking at drugs, and I don't want to overwhelm people with lots of names of different drugs, but the drug landscape has changed. And Pete, you might see this yourself when you look at the media and the news. You might hear of cannabis edibles, cannabis coming as sweets. You might hear of drugs like nitrous oxide. These are all very new, and we wouldn't have seen these so much in the past, or they wouldn't have been used as much in the past. So when we're looking at reducing harms and looking at what's going on in Ireland, we look at many different categories now. So we look at cannabis, which would be a cannabinoid, opioids, which we'll talk about, and depressants and stimulants. And I suppose for the work I do with people in nightlife settings, we would see substances like psychedelics. So that would have more of a mental effect, something like LSD or ecstasy, which is MDMA pills. And we look at trying to reduce the harms for the different substances and tailoring it for this. So the drug wheel that I have there also shows some of the new drugs. So people might be aware when we had head shops in Ireland, there was very new drugs being sold. So the European drug market is changing with new drugs, which are generally more potent in smaller amounts. And what we're also seeing is these new drugs being sold as other drugs. So this is something that we're trying to keep an eye on at the moment and might increase the risks. So to start off talking about different types of drugs, we won't talk about them all. So we'll look at key drugs. So depressants, people would be very familiar with. Alcohol is the most commonly used drugs across all of society. It is a depressant. So what that means is depressants generally slow down the system. So we all have central nervous systems. It's essentially like a computer that sends signals around our body and tells us how to act. So it involves the brain and the spinal cord. The brain is how we think and feel, and any impacts on the central nervous system will mean the messages between our brain and spinal cord and how we act and think and feel will change. So depressants are essentially slowing this all down. So it'll slow down your breathing, your heart rate, and essentially gives a relaxation, a calmness, and a feeling of being completely relaxed. So that's why we also categorize sleeping tablets, so Zimivane and Z drugs, pregabalin and Lyrica, which are prescribed for pain management, but also for generalized anxiety disorder. So there's a wide range, and I suppose benzodiazepines, which have a wide range as well. So all of them will interact in the body by slowing it down, some will last longer in the body. So when it comes to benzodiazepines, some could be short acting, medium acting, or long acting. So that means they could be present and acting in your body for a longer period of time. And the risks, I suppose, with these types of drugs is that the central nervous system slows down too much, so that your breathing becomes slow and shallow, which leads to an overdose, which is what we'll speak about a little bit later. With substances like alcohol, I suppose it's interesting to discuss the depressant effects, because for some people they could feel euphoric or high or very lively. So again, how each person reacts to a drug can be based on themselves. And coming back to my first slide in how their personal setting is. So each person will have a very unique relationship with substances, and it will be based on how much they take, what they take it with, if they do mix the drugs, and what's actually in the drug. So what we're seeing with some of the depressant drugs at the moment is newer drugs being sold. So while we see packets that look like legitimate pharmacy packets, and they're bought on the illegal market, they could be coming from counterfeit labs. So they're not necessarily legitimate medicines. And what we're seeing with some of them is that they may contain one or more drugs. So the Nike tablet in the top corner would have contained both tramadol and a benzodiazepine, so alprazolam. So that's increasing the depressant effects on the body. So that creates a greater risk. And we're seeing some newer drugs appear, and other drugs from Eastern Europe, which would be higher potency. So I suppose what the HSE is trying to do is trying to monitor and educate people as much as possible on this, in terms of there are greater risks with depressant drugs at this moment in time. Similarly, across the market, we could always see something appearing, and we always say you can never fully trust the contents, which is why we promote certain steps to help people reduce harms, which we'll talk about a little bit later. So similarly, opioid drugs work very similarly on the body, as the same as depressants, so they're slowing everything down. So opioids would be either natural, so coming from the opium poppy, or man-made, so synthetic. So heroin, and then we have more synthetic versions like tramadol, fentanyl, and methadone. And these are generally given to people in a clinical setting for relieving pain. So they have great pain relieving properties, from mild to moderate to severe pain. So people may be given opioids if they are unwell, if they are on cancer treatment, if they have severe pain. And then we know that these are used in different ways by different people. So we may see heroin in a different context. What increases the risks with opioids is the form of administration. So injecting would have a higher risk than taken orally or smoking. And I suppose what they're doing on the body is they're working on the opioid receptors and slowing the body down, relieving pain, making people feel very relaxed and calm, which could be a sought after effect again for whatever's going on for that person. So now we'll look at how these drugs interact with other drugs, which Denis will go through with you all.
Thanks, Nicki. So I guess I'm being dragged on to talk as a pharmacist. I already spoke with Nicki and Jenny, and I was going to talk about whole things around pharmacodynamic and pharmacokinetic, and I got told no. So essentially what we're going to talk about, and interestingly, Nicki brought up a very interesting depressant drug, which is one of the mixing of drugs here, which is slowing down of the system. So it slows down your breathing and increased risk of overdose. And she mentioned one of the street drugs, the Nike, which contains alprazolam being a benzodiazepine and tramadol being an opioid. So both of those together, depressant and depressant, will slow down the system. The other thing to remember always is alcohol is risky with all drugs, including prescription medication. It is seen as a depressant drug and slowing down the system. So it slows down your hand-to-eye coordination. So it can lead to more accidents, as can benzodiazepines. It can lead to deep sleep, which may result in somebody aspirating vomit. Then, of course, you've got depressant and stimulant. This will add an extra strain on the body. One of the ones that we see most with regards to depressants and stimulants is the combination of heroin and cocaine, which is known as speedball. Heroin being your depressant drug and cocaine being your stimulant drug. It adds an extra strain on the body. That what is happening here is that by the time when I take the cocaine, it goes into the system so quickly and starts, the effect starts decreasing quite rapidly, that the heroin comes in order to make my crash much softer. So it slows down the system so I don't feel that huge crash. So what it is using the effect of one drug on another drug to reduce some of its side effect process. However, sometimes with this, that people sometimes may not feel the full effects of one or the other, and this could lead to an accidental overconsumption of the drugs. So this is essentially one of the biggest concerns around the mixing of drugs, particularly depressant drugs with opioids and other drugs that cause sedation, such as the benzodiazepine, your Lyrica. So I'll hand back over to Nicki. Thank you, Nicki.
Thank you, Denis. So I suppose we've already introduced the stimulant type drugs to the discussion, and what these are they're doing the opposite to depressants and opiates, and they're speeding up your system. So they're speeding up the signals between the brain and the body, and they'd be commonly known. We see a lot about cocaine and crack as re-emerging as trends. Important to note that caffeine is a stimulant, so that's probably one of the most commonly used stimulants. And again, across society, we're seeing lots of different groups use MDMA, so that would have been known as ecstasy, and trends throughout Europe as amphetamines become more popular, methamphetamine, which is known as crystal meth. And then we also have prescription stimulants, which would be something like ADHD medication, which would also be an amphetamine. So throughout society, I suppose we are seeing the polydrug use with stimulants. As Denis mentioned, there are risks. And with the work I do in nightlife settings, we're seeing an increase in certain groups of young people using stimulants. So it's important for us, I suppose, today to talk through the different groups and the risks. And I suppose the risks would be less obvious, I think, with some of these substances when we're looking at the effects. And when we talk about the overdose symptoms later, we'll see that. But I suppose essentially speeding up the stimulants or speeding up the body, making people feel confident, euphoric, probably very visually. You'll be able to see the reaction to the stimulants. What they're doing, I suppose, internally in the body is they're speeding up the heart, they're speeding up the system, they're speeding up or increasing blood pressure. So stimulants will be an extra risk for people with asthma, for people with heart concerns or blood pressure issues. And we can see cases as well of stimulants leading to severe dehydration and different issues emerging there. So I'll hand you over to Denis again to look at how stimulants are interacting. As I said, there's a huge trend of the use of stimulants with other substances, which increases all of those risks.
So again, alcohol is implicated in a lot of accidental drug overdoses or experiences of overdose. And it's one of the most interesting one is, again, the combination of alcohol with a stimulant, cocaine, which is a very interesting drug-drug interaction, in that what happens is that a new product, a byproduct is created in the body, which has a more enhancing effect on both products, but equally a more toxic effect on the organs in the body. Also, with alcohol, there's a disinhibition associated with it for the increased consumption of more product. And also sometimes that alcohol, because it's a depressant type drug, that it may make the person want to take more because of the fact that they want to get that high from the stimulant substance. Then the other piece, that if you do that, taking the depressant with the stimulant, that you may increase the risk of taking too much stimulants, which will obviously, the most, as Nicki said, one of the major problems with these drugs is that it will increase your heart rate. It will increase your blood pressure. It can increase your temperature and the way your body regulates temperature. So Nicki will talk about later on about how to manage a stimulant overdose. And that's one of the major things with temperature, is that the person will feel hot, but they won't be sweating because their body can no longer regulate. Sweat is part of our regulation of our body temperature. It can enhance anxiety, panic, which may lead ultimately to an accidental overdose. The use of antidepressants, so medicines themselves, can interact negatively with some substances. So, for example, there's an extra risk associated with the consumption of ecstasy with some medicines, some of the antidepressants, and also with an opioid such as tramadol, which is known as Zydol as a prescription drug. So it's really important to understand that a lot of the way that mixing stimulants and drugs, that sometimes the mixing of stimulants with depressants is to get rid of one effect over another in order to have a more pleasurable experience. And sometimes by the fact that taking a depressant drug and adding in the stimulant may cause that stimulant drug to be taken more and more and run a risk of an accidental overdose. The other thing is that the risk of stimulant drug, when the person, as Nicki said earlier, with all these new emerging substances, don't know what's in this, what's in the substance, and may purchase something that's designed as MDMA, but it turns out to be a different substance. And because they know that if I take MDMA, I'll have a turn on in 20-30 minutes. However, this hasn't worked, so they start taking more, and what they find is that they overdose because they've taken too many tablets. Nicki, over to you.
Thank you, Denis. So for the final part of my presentation, I'm going to run through stimulant overdose, how to reduce, or what we would say to people if we're talking to them on from a harm reduction approach, how to identify and respond to a stimulant overdose. So we've mentioned some stimulants in terms of what they could be. So ranging from cocaine and crack, which are the same substance, they're just prepared and taken differently, and up to new drugs. So people might be familiar with snow or snow blow. All essentially have the same effects and same risks in terms of the internal speeding up of the central nervous system, leading to the symptoms that we discussed. So we do often think of depressant overdose or a person being visually unconscious or slowed down. And we tend to overlook some of the risks, I think, with stimulant overdose. So it is important for us to highlight at the moment there may be extra risks, and I know myself and Denis briefly touched on it. So throughout Europe, the cocaine strength has increased. So people may think they're taking the same amount per what they're buying, but the cocaine purity could be higher. Similarly with MDMA, it's dangerously strong at the moment. People won't know how much they're taking. One pill could actually be too much. It may be the case in some instances that they need to take a quarter or a half. So overall, the purity is increasing, which is a concern and increases your risk of taking too much too soon. People may build up a tolerance for use, so they need to keep upping the dose to get the same effects or the same feeling, and that can increase the risk of overdose. And again, the underlying conditions, anything to do with blood pressure, the cardiovascular system, your heart, can increase risks for anyone who's using stimulants. So in terms of the approach that we take with reducing harm, we apply what we say is harm reduction. So we're meeting people where they're at. So our message is, particularly when we're talking to young people or we're in nightlife, it's safer not to use, but if you do, here's some education and information which could help you. So we look at, raising awareness that the drugs could be potent or more strong at the moment. So you need to take less because of the products have changed. So lower amounts and leaving time in between use. So really waiting to see the effect. Avoid use with other substances, as we highlighted. Alcohol can mask the stimulant effects, so people might not be sure of how they're reacting. Especially you use avoiding with medicines, and we don't recommend to stop taking medicines, but for that to be considered as a factor that you maybe shouldn't be using if you're using certain medicines. Not to use alone is really important for any type of substance you were using, or let someone know you were using, just in case there is an emergency. Knowing the sign of overdose is really important for people, particularly when it comes to stimulants or drug interactions that they may present in different ways that they're not aware of. And we say knowing the signs could help save a life. So knowing the signs and responding and not being afraid. We know a lot of people are really scared to get help, particularly across society, and if people are using in different settings. So looking at stimulant signs and symptoms of a drug emergency, as I said, they may not present in a way that we're used to, and some of the symptoms could be subtle and could progress. So in general, you'd see overstimulation, someone being hyper. As Denis said, stimulants increase your temperature. A lot of people feel confused about their temperature. They're not sure how they're feeling. So visually they may seem warm, but they may feel cold. Some people feel they're unable to urinate, so they might want to drink lots of water and they think it's because they're too warm. So generally their body can feel very confused in terms of their temperature and what's going on. Headaches and pains in muscles and arms are usually a worrying sign, and not something people are very aware of when it comes to overdose. So people might think they've danced a bit too much and they've pain in their legs, but it could actually be the signs of something known as serotonin syndrome, which could be a fatal drug emergency, which is caused by how some of the drugs like MDMA interact on their serotonin system. So moving through the kind of list, you know, pain in the chest, fast breathing, feeling unsteady, vomiting. As I mentioned, the muscle pain and tremors is something people aren't really aware of. And then more serious is progressing into a seizure or a fit or activity which resembles that, which would be a more obvious sign, I suppose, than the others we've mentioned. The mental health signs are really important. And again, we tend to look for physical signs, and we might not relate the mental experience of a person as emergency, but they are in terms of stimulants and some of the other substances like psychedelics. So people could be very confused or disorientated. You might notice a really sudden change in their thinking or their thoughts or how they're acting, which could be the first sign. People, as Denis mentioned, could progress to anxiety and panic and can be very frightful. They might see or hear things that are not there and start showing symptoms of psychosis or being psychotic. So really erratic, confused, and disorientated. And they may be, you know, triggering something for a mental health reaction that people may not have experienced before. And I think when we're looking at responding to people, particularly with the mental health symptoms, we say to try and meet people where they're at, so don't challenge their feelings or, you know, say that that's not happening. So, you know, I understand what you're going through. It sounds like you're experiencing this. Really non-judgmental and friendly language would be a way we try to approach people. Of course, if it's safe to do so, so it's up to you to assess the situation. If someone is having, you know, a reaction, you have to make a judgment call if that's safe for you, if the person wants you to help them. Is there a friend there that might be able to help? That's really important. Or you could call for help and bring them in, so someone who's trained to deal with the situation, particularly if someone's distressed. In terms of you know, looking for the signs, some may be less obvious, as I said, so keep an eye out for them. In terms of the stimulant effects of the temperature, it's important to help a person cool down, sip water, remove extra clothing, bring them to a cool place. What's really important is not to give them too much water. So we might think to try and cool them down instantly, they must drink a lot of water. That can lead to overhydration, which can be dangerous because it actually imbalances the blood salts in the body, which is a fatal condition in itself. So we say, you know, don't give too much water, a pint an hour, don't give food, alcohol or other drugs to try and calm them. So we discourage that, or putting someone in a bath, people may think that this will cool them down instantly. So we have some do's and don'ts there on that list. And again, Jenny and Denis will look at, you know, the recovery position and keeping people safe in terms of an opioid overdose. And that is the same skill set. So making sure the surroundings are safe, particularly if they're fitting, keeping that environment safe and looking at the recovery position. But it's always, you know, don't be afraid to get help. Help is there, and you know, we encourage that there's non-judgmental support for drug emergencies. So that's the end. I think I did that in good time, guys. I think I'm just on the button. So thank you so much, and I'll hand you back to Denis and Jenny.
Thanks so much, Nicki, for that really informative session on drugs, what they do, drug interactions. Please, if there's any questions, please put them in the Q&A section. We're more than happy to answer questions. So I'd like to now pass over to Jenny, who's going to talk about opioid and the treatment of opioid overdose, and also to say and acknowledge here the amount of hard work and work she's put into getting this seminar off the ground. So from my perspective as the chair, I just want to make sure that people are aware that she's put a huge amount of work into this. Thank you very much, Jenny. Over to you.
Thank you very much. And thank you, Denis and Nicki, the amount of work you two have put in as well. So thank you so much. So I'm just going to share my screen there. Okay. So today I'm going to talk about how to recognise and how to respond to an opioid overdose, including how to administer naloxone. So what we're going to look at is what an opioid overdose is and how to recognise it, the opioid overdose risk factors, and then if you observe an opioid overdose, how you're going to respond. what naloxone is and how to administer it, and then we are going to watch a demonstration video today which will show us all of the steps in one place. Okay, so first of all, what is an opioid overdose? So an opioid overdose is when the body has too much of a substance that it's not able to handle it. So opioid use can lead to death due to the effects of the opioid on the part of the body that regulates our breathing. So if somebody has taken more of an opioid than they can handle, you're going to see observable signs. So the first thing we're going to say is you're going to see if somebody is unresponsive. So if you're shaking their shoulders and asking them verbally, are they okay? And you're not getting a response straight away, that's a red flag for you. So you'll be able to see if they have shallow or they're not breathing. Pinpoint pupils is another one we say. And now when you speak to some family members, they'd be able to say, yes, I can see those pinpoint pupils. Other people, I'm not clinical, I wouldn't be able to see that. So it's just one of the symptoms that you may be able to see. You'll see somebody may have pale or clammy skin. And then snoring. So it's a different type of snoring, like a rattling sound that you may hear. For people with white skin, you see that they may have blue lips and blue nails. And then for people with black skin, you'll see that they will have a grayish tinge to theirs. Okay, so these are the signs of an opioid overdose. So you don't have to see all of these for it to be an opioid overdose. If you're seeing some of these signs, respond as if it is an opioid overdose. Okay. So what are the risk factors for somebody to experience an opioid overdose? There's two, so polydrug use and a reduced tolerance, the two key risk factors. When we say polydrug use, that's a mixture of two or more substances within somebody's body. So it doesn't mean that they're taking two substances at the same time, it just means there's two in their body. So for example, if somebody has methadone, that's going to last for 12 hours within their system. So if they take something else on top of that, whether it's benzodiazepines, it's heroin, it's alcohol, that means they've two drugs within their system at any time. So that's polydrug use. So as Denis and Nicki have both covered, the increase of a risk of an overdose is when there's two depressants that are taken at the same time. So for example, heroin and methadone and morphine, synthetic opioids. So as Nicki said, these are opioids, but they're made in a factory. So for example, fentanyl, which is going to be 50 to 100 times more potent than morphine. And I think when somebody makes a decision to take a synthetic opioid, they would be aware that it's stronger, and they can maybe try and determine how much of that they can take. But in some cases, we'll see that synthetic opioids are actually in products that people wouldn't realise that it's in. So that again would increase the risk because they may not have a tolerance to an opioid at all, particularly if it's, for example, in cocaine. Prescription medications, so benzodiazepines, Lyrica, alcohol, cannabis, ketamine, inhalants and solvents. So any other medication that is going to make you drowsy is going to increase the risk of an opioid overdose. When we say reduced tolerance, so in terms of reduced tolerance, so when somebody hasn't used drugs for a while, so particularly the first 2 weeks when somebody's coming out of prison, they would be a very high risk time. So when somebody's in prison, they may have been using drugs, but they may have been of a lesser quality, or they may not have been able to get them as much, or they may not have been injecting. So the first 2 weeks out of prison are a really high risk. People return to a community, they may then start taking drugs again, and they may not be able to handle the amount that they're taking. When somebody's starting or leaving a drug treatment, and on release from hospital as well. So they would be key times. Additional risk factors, so if somebody isn't using an OST, somebody has a long history of drug use, a previous experience of a non-fatal overdose does leave somebody at a higher risk of an overdose again. People who are over 35, somebody who has mental health conditions, and we do, unfortunately, the male gender is a higher risk factor with 70% of opioid overdose deaths actually being of the male gender. Okay. So if you see those signs of an opioid overdose, how are you going to respond to that? So the first thing is going to be your own safety. So if somebody has been taking a substance, there may be exposed needles, there may be vomit, there may be blood, but just make sure, first of all, that it's safe for you to approach. And I think when you're talking in a medical setting, that's a lot easier than when you're talking about somebody that's a loved one for you. But just think, if you hurt yourself, you actually can't then help them. So the ABC response would be, first of all, you need to get somebody to help you. So call for an ambulance, call for somebody to help you. So A is for calling for an ambulance. B, check to see if that person is breathing. So you're going to open their airway and you're going to look and see, is their chest rising and falling? You're going to check for up to 10 seconds and you're looking for 2 breaths. So if they are breathing, you're going to put them into the recovery position. And if they're not, you're going to start CPR. So you're going to start chest compressions, and then you're going to administer naloxone. Okay, so that's our ABC response. Okay, so I'm going to ask Denis then, if you don't mind, as the pharmacist coming back in for me. So Denis is just going to explain to you what naloxone is.
Thanks, Jenny. So naloxone is it's an amazing drug. Jenny will talk later on, but it's really an intervention of time to give people time for an ambulance to arrive. And as Jenny clearly said, that it's really important that an ambulance is called, help is called for if you suspect someone is having an opioid overdose. It is a prescription only medicine in this country. And as I said, it's a temporary reversal. It works for about 20 to 90 minutes. And the issue with it is that somebody who you may have used naloxone on and decides that they don't want to go in an ambulance and decides they're going away somewhere or disappearing, they run the risk of relapsing into an overdose. So essentially, as the picture shows here, it's very clear the opioid sits in these parts of our brain we call receptors. And what happens is that when naloxone is provided, it gets rid of the opioid, the heroin, the methadone, the fentanyl off the receptor and sits on that. So it allows certain certain parts of our body to return. So our breathing will improve. So what happens is that we become to breathe more normally. The other thing to remember is that naloxone does precipitate, it's a withdrawal. So people will go into withdrawal. So remember that it is the complete opposite of what heroin does. It stops it working. So it makes the person go into withdrawal. So that's what naloxone is. I think, Jenny, if you go on to the next slide.
I'm going to ask you then, Denis, if you don't mind telling us about the different types of naloxone that are available.
Thanks, Jenny. So as I said, naloxone comes as either an injectable form or intranasal form. So the injectable form is known as Pranoxad. Pranoxad is a 5-dose individualized use injectable with 2 needles in it. These 2 needles are in it, not that you change the needle, that you use the same needle 5 times on the same individual, but it's in case you drop the needle or accidentally it breaks or cracks or something happens to it, that you have a replacement needle to put on to the injection. The important thing to remember with Pranoxad is that people ask, oh, how can do you have to take clothes off? No, this goes straight through the clothes into the middle third of the thigh, which is a very heavy muscle. So it's really easy to administer it. And it's an amazing piece of its agreement on the market is that it can be administered by people in the community. You don't have to be professionally qualified. And this is why we're doing part of this training, so that you're empowered that if you want to use a product like this, that you can access it. The intranasal naloxone is really a simple product. It's called Nixoid. It's essentially like a Vicks Sinex nasal spray. It has a little mechanism in it where you depress the middle part of it up the nose and you use the second dose in the other nostril. So it's a very simple, non-invasive piece of equipment versus the injectable. We found in our experience, Jenny and myself, is that a lot of family members prefer the nasal product versus the injectable product. And that's over to you, Jenny, for the video part, so people know how to use it.
Thanks, Denis. So as Denis said, we have found that family members do prefer the nasal spray. So what I'm going to ask Jean to do is share the video with us. So this will show you how to administer the nasal spray. Now, the injectable there is also a video available for that, which is on drugs.ie, and we will send out the link to bring you to that one. But I'll just ask Jean to share the nasal spray video with us today.
How to respond to an opioid overdose and administer intranasal naloxone. Naloxone should be administered to a person experiencing a known or suspected opioid overdose as an additional support until an ambulance arrives. Please follow the recommended PPE guidelines at this time. The signs and symptoms of an opioid overdose are any combination of shallow or no breathing, snoring or rasping sounds, a bluish tinge to the lips and nails in white skin, or a greyish tinge in black skin, no response to noise or touch, small or pinpoint pupils, pale and clammy skin. If you see any of these signs, call for someone nearby to help you, call 999 or 112 for an ambulance, providing your air code if possible, and ask someone to fetch an AED and naloxone. Before you approach the person, make the area safe by moving anything that may harm you. Check for response to sound and touch. If there's no response, open their airway by gently tilting their head back and lowering their chin. Check to see if they are breathing for no longer than 10 seconds. Can you see or feel their chest rising? If the person is breathing, move them onto the floor, administer naloxone and put them into the recovery position. Each box contains 2 individually packaged nasal sprays. Each spray contains 1 dose of naloxone. Do not test the spray before use, as it will spray and cannot be reused. Administer the first dose while the person is on their back. Tilt their head back. Hold the spray with your thumb on the bottom and your fingers either side of the nozzle. Gently insert into the nostril. Press the plunger until it clicks to give the dose. Remove from the nostril. Put their nearest arm in a high five position. Put the back of their hand to their cheek and hold it there. Bend their far knee up and tuck their foot under their other leg. Pull the knee to roll them over. Tilt their head back and lift their chin to open the airway and straighten their leg. Repeat a cycle of monitoring the person for 2 to 3 minutes to make sure they are still breathing. Administering further doses of naloxone while the person is in the recovery position, until the person is responsive or the ambulance arrives. If the person stops breathing normally, start chest compressions. If the person is not breathing normally, move them onto the floor. You need a flat, hard surface to start chest compressions. Chest compressions will do the work of the heart by ensuring blood continues to be pumped around the body. Place the heel of your hand on the centre of their chest. Interlock your fingers and with your arm straight, press down on the centre of the breastbone, 5 to 6 centimetres. Repeat this 30 times, then administer naloxone. Repeat a cycle of 100 chest compressions, then a further dose of naloxone until the person is responsive or the ambulance arrives. If the person starts to breathe normally again, put them into the recovery position. Remember, check the area and make it safe for you. Call for someone to help you. Check for observable signs of overdose. Call 999 or 112. If they are breathing, put them into the recovery position, and if not, start chest compressions, administer naloxone and wait with them until the ambulance arrives. Recognizing an opioid overdose and administering naloxone can save lives.
Thank you very much. So I'm just going to, oh my apologies, I'm just going to share my screen again there. Okay. So thank you for showing that. So what I've done then is I've pulled together the most commonly asked questions and fears that people would have about naloxone. So the first one is, what if it's not an opioid overdose? So if it's not an opioid overdose, naloxone isn't going to have negative impact on somebody. So if you see the observable signs that we've just spoken about and you administer naloxone, it's going to take away that chance that it was an opioid overdose. So if you see those signs, administer naloxone. As I said, there isn't going to be a negative impact on somebody if it isn't an opioid overdose. We have the 2 different products that Denis just talked through with you. You can see the Prenoxad, which was the injectable, has 5 doses within it. And one of the fears that people have is that they may inject too many doses. So what we say is inject 1 dose at a time and follow a cycle. But in that situation, if you have a loved one in front of you, it's very easy to administer more doses of naloxone. So you may go down to the second black line because you're in a panic and you're administering it in that situation. If you administer more doses, that's absolutely fine. Don't panic about that. You know, you're not a trained medical professional. You're in a very stressful, upsetting situation. Administering an extra dose is going to be absolutely fine. People do ask in terms of doing CPR, what if I break or crack a rib? Unfortunately, that is one of the risks of CPR. But when you're performing CPR on somebody, you are doing that because they're not breathing. So you're performing CPR, doing the work of the heart by pumping the blood around the body. So unfortunately, if a rib does break, you're going to carry on doing that to help save that loved one. And then what if you drop that naloxone and it's wasted? If you drop it and it is gone, unfortunately, you haven't got it to administer. You'll just let the 999 operator know that you haven't got naloxone to administer, and wait for medical care to arrive for you. So you're doing the best you can do, and that's all anybody can expect of anybody. How to obtain naloxone is something that obviously we're asked. We're going to show you how to use it today. So how do you actually then physically get naloxone? So it is a prescription only medication. So it's prescribed by a doctor, or it can be provided through a drug treatment or support program. So what we ask GPs to do, there isn't a limit on how much can be prescribed to somebody. So we ask GPs in the first instance to try and prescribe 3 units. So that means then somebody who is at risk of an opioid overdose has 1 unit of naloxone to keep on them. They can leave one where they sleep, whether that be a hostel or whether it be in a family home. And then they can also give one to a loved one or to a significant other if they've received training to do so. So the key points from my own presentation would be, first of all, make sure that area is safe for you. I appreciate that that's going to be a very difficult thing if you have a loved one there who is showing an opioid overdose symptoms, but make sure it's safe so that you're still in a position to be able to help them. If you see observable signs, call for help, call 999. Check, are they breathing? If they are, put them into the recovery position, and if they're not, start chest compressions. Administer naloxone, and then make sure that area is safe for others. In terms of from an expiry date, so naloxone does have an expiry of 3 years. So if that date has passed, you're better to use naloxone that's out of date than not to use anything. And then if you do use naloxone, try then to get a replacement, because obviously your loved one, if they do have an overdose, unfortunately becomes at a higher risk of overdosing again. So do get a replacement so that you have it in case of another drug emergency. Okay, thank you, Dennis.
Thanks so much, Jenny, for that. So tonight, as the end part of this, we had asked family members for some questions and answers, some questions that they would like answered. So what we'll do is I'll display the questions, and we'll have a quick discussion between Jenny and Nicki and myself around it. Please put some questions in the Q&A session. So if I'll just share this with you, just give me 2 seconds. Okay, so one of the first questions we asked is how, and it was mentioned earlier tonight by Jenny around fentanyl and its potency, so meaning how strong it is. And it's like, how effective is naloxone if a person is overdosing on a fentanyl? So Jenny, Nicki, I'll hand an answer over to you on that, and from the evidence around naloxone and its ability to reverse a fentanyl overdose.
Yeah, so naloxone is still going to reverse a fentanyl overdose. It is a synthetic opioid, so it's still sitting on those receptors within the brain. However, because naloxone is stronger, fentanyl is stronger, you may need more doses of naloxone to be able to reverse that effect.
And I guess the other thing just to add in there is that in the States, where we have a massive fentanyl use, that naloxone is seen as like a primary life-saving medicine to be made available to those people who are using fentanyl. So we know it does work for fentanyls. I think it's like everything, Jenny and Nicki, you'll probably concur, is that you need to get in quick with it, particularly with the fentanyl use, because fentanyl is so potent and acts so quickly. Another question that was asked was, and I'm going to speak to both Nicki and Jenny on this again, is the evidence around how good is naloxone at preventing overdose deaths?
I think I'll jump in, Nikki, if that's okay. I think in terms of that one, obviously, Denis, it's hugely successful at preventing overdose deaths. If we look at the data that is submitted to our office, we had 569 recorded administrations of naloxone. Of that, 98% of people's lives were saved at that point from having naloxone used. So 98% of those administrations, the person actually survived that overdose.
And I'm going to put in a piece, Nikki, sorry for, is that when we started this project in 2015, we had 600 units to be used at the time to do our demonstration study to show its effectiveness. And when we looked at international data, it demonstrated very clearly, and Nikki, you were with me at the time doing some of this work, was that that in the space of the 3 months of the study, that it had been used successfully on 3 occasions, which linked very well with international data. So we know naloxone works. It's just a matter of having naloxone at the time to use it in an accident, in an opioid overdose.
And I think, Denis, sorry, just one bit added to that, and I suppose just in terms of the data that I gave, when somebody experiences an overdose, it isn't necessarily going to be a fatal overdose. So we can't assume that on those 569 times, all of those would have been fatal if naloxone hadn't been administered. However, I suppose from a family member, if it was my family member, I wouldn't want to be playing Russian roulette to see, actually, is this going to be a fatal or non-fatal overdose? So to be able to actually have that take-home naloxone at home that I can administer, and I'm not sat waiting for an ambulance and medical care to arrive, I have something to do in the meantime, is a huge tool for people.
Yeah. And I think that's the piece here. If we look at data coming out of other jurisdictions in the States, particularly where naloxone is used as almost a drug treatment, because rather than intervention, whereas here in Ireland, it's definitively seen as a drug treatment, as a drug intervention in order to give time for an ambulance to arrive, rather than a drug treatment. So Nikki, if from your perspective, Nikki, I guess I'm going to throw this question at you. From all the time you've worked with us on the project, which goes back a long way, and I know in previous roles you'd have had a huge interest in this area. In your experience, how long does it take once a naloxone has been administered to work in your experience?
Thank you, Denis. And I mean, Jenny might back me up on this from her recent work, but it's instant. Look, it's a really quick tool. What I could say is it's a pity that we don't have such a tool for other overdoses, because as you guys have said, it's so effective, it's quick, it's effective, and it does give us that time, I suppose. I know people do fear that there may be more potent drugs or other issues, can give people that reassurance of a quick response to maintain that status. So I mean, Jenny, you might have something else that you want to say there. As the naloxone lead.
Yeah, no problem. And it's great because there is experience through the whole team. We are very lucky, and I think, as you said, Nikki, it'd be amazing if you could have a product that would do for every type of overdose. If we look, for example, at this year, we've had 45 reported incidents of naloxone being administered. And of those, 1 to 2 doses seems to be the normal amount of doses that are required. So if you think in terms of that video, you're administering the first dose and it's 2 to 3 minutes before you're administering the second dose, but it's only needing 1 or 2 doses to be able to have that person breathing again. So, 3 to 6 minutes is what you're looking at, really.
Yeah, I'd agree. Its onset of action is quite rapid, within 2 to 3 minutes. And as Jenny said, from our experience, it's been 1 to 2 doses. That's the normal, but there have been abnormal as well. So people need to be aware that it's not, there have been more uses than 2 doses. And often it's, if let's say you're in a situation, you've administered it twice, that doesn't mean stop. No. Keep administering until you get a result is the most important thing. And always to remember is that whole piece, which both Nikki and Jenny spoke about, that in an overdose situation, you've called for help. Remember, you have essentially an expert at the end of a telephone line on the 999 112 call who will advise you and say what to do next. So that's really important to have that there.
Sorry, Denis, just to make sure, because I think that is a really important point, that when we're saying on average 1 to 2, we have had a couple of examples where there has been 10 doses of naloxone given. So there shouldn't be a fear of administering that naloxone.
Okay, perfect. Thanks a million. The other one, I'm going to answer this. My loved one uses, where can I get naloxone? So this is my hobby horse at the moment, and I'm sure Jenny and Nikki are tired of me talking about this. It's in the National Drug Strategy that we have a wonderful line in it where it says the availability of naloxone should be widely available to all people who use drugs, their families and loved ones and nearest and dearest. Currently at the moment, because it's a prescription only drug, the only people that can access it is for those who need it themselves. So your loved one who needs to access it from their GP, from their doctor, and they can be prescribed naloxone. And the whole thing here is that they need to ask for more than one product. They need to ask for multiple products, as Jenny said earlier in her slides. I would even say 3 or 4. So it should be treated like an emergency drug. So if any of you know anyone who has allergies to peanuts, they always carry more than one adrenaline pen on them. They have more than one adrenaline pen around the place. So that's what it should be treated like. So unfortunately at the moment, there is that a slight block for wider availability. That's not to say that we are seeing that the challenge of this and our vision on this is the wider availability as per the National Drug Strategy. I don't know if you have anything to add in there, Jenny or Nikki.
No, absolutely, Dennis.
Okay.
It's just making that increased awareness and increased availability.
Okay, so can naloxone wear off, and if so, can someone die of an overdose? I think I spoke into this earlier when I said that, yeah, naloxone lasts approximately 20 to 90 minutes, depending on the situation and depending on the individual. And yes, the problem with that is that it is a temporary reversal. The word is temporary. So if the person decides, you know what, I'm out of here, I'm going to go off, the risk is that they'll be on their own and may relapse into an overdose or decide to use more substances on top in order to go back into that state of being intoxicated, which runs an even higher risk of a further accidental overdose. So yes, is the problem with the drug. It's a temporary reversal. Can you inject naloxone through the clothing? Jenny, I'm going to hand that over to you because we did a lot of videos on that.
Absolutely. So yes, absolutely, you would inject it through somebody's clothing. The only clothing you wouldn't be able to inject it through would be if somebody was wearing leathers from a motorbike. We showed you the naloxone, the nasal spray video today, but if you go onto drugs.ie naloxone, you will see there's a demonstration video showing you how to use the injectable naloxone. But yes, absolutely, through clothing.
So question 7. So Nikki, I'm going to throw this at you. Is it true that a person may become agitated after naloxone is given?
For the reaction will be different. It's not necessarily that people do become agitated, but it can happen. I mean, each person has a different reaction to the response. I mean, some people could go into different states. So I think, look, every situation is taken as different. So not every situation, but it can happen from time to time, depending on where that person's at, their mental state, what that dose was doing for them at that moment in time, where they were, who they were with. And it can come back to what we discussed at the start and the drug setting and thinking about each person being very different, and it's a very individual thing. If I'm right, I could be wrong, but could some people go into withdrawal? Could some people become very unwell? So we have to prepare for every eventuality, I suppose, with it, and it's important to have the discussions that of what could happen or what could emerge in that situation. So, I mean, look, Denis and Jenny, you might have some more anecdotal feedback from what people experience on the ground with that.
I think it really does, as you said, Nikki, it really varies. And I think it does vary as well, depending on not only the person, but the person who's administered naloxone, particularly if you have a peer or a family member or a support worker that so you know that they haven't administered naloxone from a judgmental point of view because you've taken a substance. They've given it you because they observed signs of an overdose and they actually were in fear of your life. So they've observed naloxone, they've administered naloxone for that reason. But yes, naloxone is going to take away the effect of whatever opioid they've taken. So they are going to go into a withdrawal.
Yeah, and I concur with that, Jenny. And you said it earlier, Nikki, when you were talking about overdose and the stimulant, that having someone they know there really is important for keeping them calm when you're bringing them out of their turn on and you're trying to save their life and trying to explain that to someone. And as Jenny said, once they know someone, there tends to be less agitation around it. So it's really important that you speak lower and that you bring down your voice and you explain what's happened. So
I'm just going to jump in very quickly, Dennis.
Yeah.
I see one question left here, so if I let us answer that, and then I can see there's a couple in the Q&A, so I might just address some of those then, if that's okay.
Perfect, Jenny. Yeah. So the last question I'll answer very quickly. No. And naloxone is an amazing drug. It's there to as an antidote for an opioid overdose. There's no such thing as an immune response to it. You cannot develop an immunity that you need more and more of it. So Jenny, over to you.
Thank you. I'll just jump in with some of these now. We'll just try and answer as many as we can today. So in terms of the recording of the webinar, so it has been recorded today. As soon as the link's made available, we will put it up on the drugs.ie. We'll put it up on the Families Matter page where you registered today. Are the slides available? We won't have the slides available, but they will be available as part of the recording that you're watching with the slides that we've used today. Is this free once it is prescribed? So if there is a prescription for it, there is, I suppose Dennis is looking at me now to see how I'm going to answer this. So there's two different products. Your Nixoid, if that's prescribed, is reimbursable through the PCR. Tell me the letters again, Dennis.
PCRS, yeah.
Thank you. But Prenoxide currently isn't. However, if the product is supplied to your loved one through a support service or a drug service, then yes, it will be free. So that shouldn't prevent them from
So
gaining
Jenny,
that.
just to explain that if they get Nixoid from their GP prescribed to them, they pay their GMS fee of €1.50.
€1.50, isn't it, Dennis? Yeah. But they won't actually pay for the product itself.
They don't pay for the product, it's
No.
just the fee. Yeah.
But the Prenoxide, the injectable, yes, you would. But if you're getting it through a drug treatment support service, no, there's not going to be a charge for that. Okay.
Perfect.
Thank you. And then, sorry, I'll just read this one through and then we might just have to have a look at it for an answer. So in a drug treatment detox centre, could naloxone be used initially instead of methadone and treat the symptoms of withdrawal that occur? I think, Dennis, you might be best placed to take that one if that's okay.
Okay, so methadone is used as a opioid agonist therapy, OAT, or it's a substitution treatment, and that prevents withdrawal. If I gave naloxone, it causes withdrawal. So it's not that it could be used to prevent withdrawal. It's actually there as something to cause somebody to go into withdrawal. So it can't be used like that, essentially, is the bottom line. You'd only ever use something in detox would be a similar type of drug in order to treat the issue. So an opioid to treat an opioid is the normal routine, be that buprenorphine or be that methadone. Naloxone, there is an oral form of naloxone called naltrexone, which is sometimes used post-detox as a help for people so they don't relapse into using opioids again afterwards. But there's an inherent danger around that if they do relapse, they can actually overdose really quickly because they can actually override its blockade effect. But that's a completely kind of different scenario, but it's another product that could be considered, but not naloxone itself.
Thank you, Dennis. And I'm conscious that it is 8:01, so we'll just answer this one last question, if that's okay. So is there any movement on making the drug available, for example, for the Gardaí or for support staff? So in terms of that, a site can register to be a listed organisation and actually hold naloxone on site for use in an emergency. To do that, that's in line with the SI 449 and I'm going to say 530 off the top of my head legislation. Dennis, you can correct me if I'm wrong. So in order to do that, the staff would have to have accredited training, which is available, and then they would have to register to then hold naloxone on site. Dennis, do you want to add anything extra into that one?
No, like the whole thing here is that the project, the design of this project has always been for its wider availability. If that would include the Gardaí carrying it, that other agencies should have it, then that's the movement we're moving forward with. Currently, SI 449 and SI 520 rather than 30 would the whole point of this is that SI needs slight modification so that it's more, we can make more organizations being able to access it to become, they become centers where they can actually hold the naloxone in order to administer it on site. That's a small bit of work in progress at the moment, but everyone needs to know that the work that's being put in is just our aim is to have naloxone as widely as available as possible and as widely known to organizations as possible. So for example, and Jenny can speak into this, is that we've developed information Jenny's going to call it something else, but an information piece for the Gardaí, so they're aware of what naloxone looks like if somebody has it on their person, and equally they're aware of what an opioid overdose looks like, which is a huge step forward. The whole aim here is that ultimately it will be similar to how it's happening in Scotland and England with regards to the police forces over there.
Yeah, and I suppose at the moment, Dennis, but just to add to that, so yes, e-learning is what I'll call it. So our e-learning for both GPs, but also for An Garda Síochána. So there's two elements to that. It's one for the GPs in terms of prescribing it and asking them to prescribe 3 or 4 units, so that one can always be left in, for example, in a service where people are being supported, so they do have it available that way. But also then, you know, as a guard, if a guard knows how to administer naloxone, then yes, they can administer it as well, because naloxone is designed for lay use, so you don't have to be a medical professional to administer it.
Perfect, that answers that. Nicki,
Thank you.
anything? Okay, so I'm going to close off and
Thank you,
say
Dennis.
thank you so much for everyone who attended tonight. I appreciate that for some of you here, it was an extremely difficult piece of information to get. My experience of this has always been that it's afterwards when people process this, and to remember to go onto drugs.ie. There's a lot of help and support on that. And I'd like to thank both speakers tonight, Jenny and Nicki, for their piece of work, and also to thank our webinar hosts, Jean and Lauren, who are in the background. And on that note, I'm going to say good night, have a lovely evening, and hopefully you'll feel that this will empower and that we can move forward, that this was the start of the rolling stone to get more and more people involved with getting naloxone more widely available. Thank you so much, everyone.
Thank you.